Hi, everybody, and welcome back to Blueberry Pediatrics Podcast. I'm your host, Dr. Lyndsey Garbi, Chief Medical Officer and co-founder of Blueberry Pediatrics. I'm a board-certified pediatrician and neonatologist. And on today's show, we have Dr. Lyndsey Garbi.
Very exciting.
I'm so glad you're here for so many reasons. I'm going to tell everybody all about you, and then we'll get into it. And the most important part, obviously, is that we have a past history together.
That's right.
All right, so Dr. Lyndsey Garbi is Chief Medical Officer at Progeny Health. She oversees medical management and quality operations there. As an experienced physician executive who is focused on maternal health care, Dr. Genen most recently served as a senior research fellow for United Health Group Research and Development, helping to advance research and develop innovations in healthcare. Prior to moving to R&D, she was recently the Chief Medical Officer for Women's Health at Optum, serving fertility, maternity, and NICU programs. Previous roles involved National Medical Director at Paradigm Health and Alere. Dr. Genen earned a bachelor's degree in chemistry and graduated with honors from Wellesley College. She received her Doctor of Medicine from the State University of New York Downstate Medical Center. She completed her pediatric residency at Columbia Presbyterian Babies and Children's Hospital and her neonatology fellowship at Yale New Haven Children's Hospital. Dr. Genen became interested in clinical research and had attended the Yale School of Public Health during her fellowship, where she earned a master's degree, like as if MD wasn't enough on top of that. In public health, focused on evidence-based medicine. Dr. Genen also worked clinically as a neonatologist at Northwell Cohen's Children's Hospital and as an assistant professor of pediatrics at Hofstra University Medical School. So that's the part where we overlapped in our careers.
Right.
I trained under Linda and then worked as her colleague. Was very lucky to have time with her before she went full-time and dived into this other space of medicine, and the administration business side of it, which is extremely interesting, and I'd love to learn more about. Welcome, Linda.
It's so great to be here. We've been passing each other quite a bit over the last couple of years, so I'm glad we took time today.
For me to enter your space was very exciting because I had known about it for a little while, and then I was like, wow, this is what you do. And to see the other side of things is eye-opening. So I'd love to hear about your career path and how you you were motivated to move into different spaces and the trajectory.
Okay. So you already gave that great bio. Thank you so much. I thought I was going to be a neonatologist forever, full-time clinical, obviously lucky to always be at academic centers where I could teach also, which was great. I really thought that was it. That was all I wanted to do. So I was pretty happy with that. And then one night, very busy night in the NICU, I said to the secretary, you go get dinner and I'll handle the phones. And that evening, early evening, someone called, a medical director from a health insurance company, or so I thought, called and said they were looking at a baby I wanted to transfer to go to a step down, so feed and grow. So a baby who was preemie initially and then ended up needing further care, but not a level 3 or 4 NICU where we were. And the person on the other end of the line spoke really well or eloquently, understood the words of neonatology, which, as you and I know, is unique compared to any other part of the hospital or medicine, even pediatrics to some extent. Yeah. We have a whole bunch of alphabet soup acronyms. He knew it all. And so we started talking, and then he said, I work to help health plans understand their NICU costs, understand why they have to cover things, also understand and help physicians as to what's the best approach with regard to the use of healthcare, right? How do we monitor our healthcare utilization, as well as be a liaison? So a liaison between the health plan and the bedside clinicians. And I was truly very intrigued with this concept because I had not had exposure to health insurance calling into the NICU, asking questions, or asking to talk to the physicians making decisions. So it opened a whole nother world of what's called case management and utilization management. And I never understood, this is before we were electronic EMR. So there were people in white coats who would come into our NICU and look at the charts. And I was like, what are they doing?
I forgot.
They had a badge. They had the hospital badge, but I knew they weren't on staff because I wasn't engaging with them. So they were going and gleaning information from the chart and getting that information back to the health plan, who would approve continued stay for these babies. So it was just a world I'd never heard of. And 6 months later, I joined the world. I ended up, they said, oh, we actually are running a research division associated with Jefferson Medical Center in Philly. And we'd love you to come continue doing research, which sounded great. As an epidemiology person, there was a lot of data. They had all this claims data. They wanted someone to help them run that research part and learn about case management and utilization management. So that was my big jump. And it was a big jump because I went from being so immersed in the NICU and not realizing that actually I had burnout before burnout was a word.
Mm-hmm.
I didn't understand that I was 24/7 running around on call. I was, running the regional perinatal center and doing a lot of trying to do clinical research as well as teach and be on service. It was too much.
It is a lot. A baseline without adding more, and then family life. It is a lot.
Yeah, forget it. The kids never saw me. Lyndsey knows, 2 boys never saw me.
Yeah.
So this was an opportunity to take a breath, and I stayed clinical. I actually stayed clinical all the way into the beginning of the pandemic. So I ended up being a 1.5 FTE. So working full time, doing the day job, so to say, and my nights would be on call, and ended up loving what I was doing because instead of just focusing on the babies in front of me in my NICU, now I was focusing on babies across the United States. And having come out of an MPH where I'd done a Cochrane review, evidence-based medicine was really important to me. And we are not really great in neonatology at always following evidence-based medicine. You get a bunch of us in a room and not everyone agrees on the way the guidelines should be applied. So it was really interesting to see the health plans want to pursue evidence-based medicine, the precursor essentially to value-based care that we see now, where they want guidelines in place and look at outcomes.
Yeah, absolutely. And we're not taught this stuff in medical school.
No.
And it's almost like we're opposing insurers and payers and as if we're not working together and they're the enemy, which once you dive into the other side of the world, you see it's very different than that preconceived notion.
That's right. And so that's exactly right. What happened was actually there were people that were upset that I went to the quote dark side of medicine. Some friends were like, oh, I can't believe you're doing this. And others who were thrilled because I actually understood the language of neonatology. So it was really mixed reactions from people. And bit by bit, people were like, oh, I'd rather talk to you than a cardiologist on the other end who doesn't understand. And so that's the goal. The goal of these conversations aren't to be about, we're not going to pay for something. Let's understand what the best needs are and how do we help you solve for those needs.
Right. Because then you have so much data to work with. I'm sure that was, that's a lot of what you did was look at the data.
That's right. It was so great. So, and for us as neonatologists, we're so focused on what's happening immediately. Like who's trying to die today? That's a big part of what we do is the critical half of the stay. But there's another part of the stay that we don't have as much time to focus on. And then you add in social determinants of health. So then there was this whole world of, oh my God, we are not addressing the issues in the NICU that we need to address. If you just start with mom, right? So normally you and I get sick. The goal is to get us healthy and go home and take care of ourselves. But for the NICU, the goal is to get the baby healthy or ready for discharge and the parents because someone's got to take care of the baby. So this opened a really big world for me that was lacking clinically because we were never fully staffed to have enough discharge planners or social workers to help the families navigate this very scary situation. And 50% of the births in America are Medicaid, which means you have people who really are in need in navigating the system. But I will tell you, all of us need help navigating the system, as you know.
100%, yes.
So it really, to your point, understanding both sides of medicine, the insurance side, the business side, us as clinicians, being really owners of how we use our healthcare dollars to some extent little things like being aware that I used to just transfer a baby in the middle of the night to wherever I needed to. I didn't think about that hospital being out of network and then the results that might happen for that family if they then had to pay something that wasn't covered. Now we try and think about it a bit more, but years ago we weren't doing that. And even today we don't. We're just calling around who's got a bed. Let's make this transfer happen. So these are things that you learn along the way. And so it was a great transition. I'm super happy I did it because now I felt like I could affect outside of that small NICU, a much larger population and really help more women and babies. So,
which is what you're doing exactly at Progeny Health.
That's right.
Yeah. And in your role, do you feel that you've been able to make a big impact with the data and with implementing all new types of programs to address the social determinants of health, which I'd love to get into more as to what these are and how they're actually saving money by putting in programs to help mothers and babies?
So what was interesting, so when I joined Progeny, which is about 4.5 years ago now, Progeny was very focused initially on NICU. Amazing focus, right? And Dr. Ellie Stang had originally started the company over 20 years ago now. So it's really had great sustainability if you think about it. Then I came in and was lucky enough to be part of that team that was building a maternity program. So now not only did we do case management utilization on babies, now we were touching the moms. And we built that program. We really, it makes me smile. We built it in 9 months. So It was literally a 9-month gestation, launched it 3+ years ago, and have touched thousands of women. And what's been so interesting is it is all case management. We are solving all those social determinants of health. That's what's so interesting to all of us in it. We knew there was a lot of non-clinical issues that people were facing, but it's truly amazing that if you think about your maternity journey, right? You go into the OB, you may not see the same OB at each visit. If you're in a practice or a clinic that's not a single or dual OB, you are seeing a different doctor each and every time. So that person, and the goal is so you know them a little bit if they are the OB on call when you deliver. I get the model. The downside is they don't really get to know you. You spend 15 minutes, you're there mostly naked, cold, uncomfortable. It's not a great setup to build a relationship where you're willing to tell someone, by the way, I'm using prescription pain meds, or by the way, I don't feel safe in my relationship and I'm at risk. So we're the case managers that work with the women that we're engaging with are building this trust because they're talking to them a lot and really talking to them on the phone, not just through an app. So that's a big part of it, that yes, we do have an app, but it's that personal touch. Building the trust is so important. And we're learning and seeing all of those things such as transportation. If I can't, so let's talk about
my appointment.
Right? We've got 51+% of the counties are an OB desert. I mean, there's no OB, maternal OB care in a reasonable time, drivable distance. So we're solving for that, right? We have women who can't get appointments. So access to healthcare is a problem. We all know it. I can't tell you how many times my chat blows up. Do you know someone? Can you get me an appointment quick? Yeah. Not even an OB anywhere. It's very hard. And you and I live in a very physician-rich area. So it's very challenging. So now you add in a language barrier, right? Someone who doesn't know the culture or doesn't speak the language. Transportation, can't get to the doctor, can't get into the doctor's office. Can't get a postpartum visit, by the way, which is really necessary.
Wild.
And we're solving for all those issues, right? So there are the medical concerns, obviously, gestational diabetes, hypertension, but those social determinants of health, behavioral health, massive problem. We don't have enough of a network. I need more people who specialize in perinatal mood disorders because not everyone does. So it feels a little bit like I'm constantly pushing a rock up a hill, quite honestly.
Yeah, I could absolutely. And I think when you see the such a benefit to your role that you have the physician background, because when you look at the physician side of it and the OB that's in the office who doesn't have the time to engage about all of these things, which I mean, as a practicing doctor myself, I really wish I could get to know everybody to this level and depth and
Yeah.
sort out issues that prevents them from being able to come to the hospital or not. But we don't have the time, unfortunately, to
No.
do this to the extent that we want to and probably should. So I think within that system alone, there are issues that the healthcare system is not designed properly to allow us to do those type of things, which
It's
clearly creates the need for companies like Progeny. And is there a model or system? Is this like really value-based care then that we try to instill where doctors would have the capability to do this or work this into their offices even?
Right. So it would be, it's challenging because it costs money, right? And so it's hard for a physician to hire even one case manager. Let's say a maternity practice that I know very closely and have worked with, they would love to have one or two case managers. They just can't afford it, honestly. That's the challenge. So they end up doing what they can here and there. So it depends on the practice. Some of the larger practices, so there are very large OB practices across the nation, they've been able to put in case managers and even behavioral health people at times. So it's changing. It's definitely changing.
Okay. But I think that they're not even motivated to those all the time. Monetarily, right. It's disincentivized. They're going to spend their money from the office to help their patients, which everyone altruistically really wants to do. Yes. But then where's the return on investment for them? It's probably not there because they're not getting paid on better outcomes necessarily.
Right. And if you think about the average day in a physician's life, not, we'll say, out of the hospital, right? We see this all the time. People, you and I, friends of ours, they've worked all day. They may have started at 7 a.m., literally. Yep. My OB, who I love, starts at 7 a.m. Mm-hmm. And will work probably till 7, then goes home and does some charting as well. Somehow we'll have a scribe with them. Then there's billing. So there's tons of paperwork. So now you're faced with, I've got a patient who's got suddenly a need that I need to solve for socially, a social determinant of health, let's say. And I, as the physician, don't have the bandwidth or time to solve that problem. So the beauty of having the programs like Progeny is we've built a network. So as we work with each hospital or state in that region, we know what are the community resources I can send that woman to. For example, the formula shortage, right? When there was an issue, we didn't have enough formula. Our team really rallied and was able to get resources so that women could get formula for their babies.
Yeah, that's incredible.
Whenever now as extreme weather gets worse, right? Whenever there's an alert, we actually watch the weather, and no matter what hour, suddenly our team gets activated. So there's a hurricane in Texas. That's a state that we're in, of course. We immediately start calling members. We have a phone thing that goes into effect. And these are our case managers getting on the phone, reaching out to every single member to make sure they're okay, or what do they need if they're not? I should say, and what do they need if they're not okay? Yeah. So these are things that we're just not set up for as clinicians.
Right. It's nothing that we're even thinking about, to be honest. Is, we care about our either the babies, the patients, the kids, or the adults, but that's amazing. So this is sometimes a challenge that I find within general populations, Medicaid populations sometimes too, where it's hard to engage them or be able to create that trust. Is this a challenge that you have with Progeny?
Everyone has this challenge, right?
Yeah.
Every health plan we talk to, every practitioner we talk to, it's definitely a challenge. We are better at it. Than I've seen, quite honestly, in my history. I feel this program, having worked in many, many other programs now in NICU and maternity, I have to say we have really constantly focusing on how do we engage people. And what we do find, so for years I just thought an app, right? Just give people having babies are younger than I am now. And everyone's got a phone, a smartphone or a burner phone, just give them an app. But if they don't know about the app, they don't use it, right?
Mhm.
If they don't know about the program, they don't use it. So one of the issues we run into, and I tell this to everyone, by the way, when I see people for dinner, right around the time you're switching your health plan, look into all of the benefits that your company is giving you.
Yeah.
What are all the programs? We all know about health insurance, dental insurance, and vision, but there's things like breast milk shipping that a company might give you, or paying for a pump. So I tell this to mostly women because women are the CEOs of our lives. And so they're the ones who investigate this more often, I find. Things like breast milk shipping, I found was under the EAP, like the Employee Assistance Program. Well,
Mhm.
most people don't go there unless something bad is going on in their life, right? Like things like if you need an attorney, that's under the EAP, divorce help, EAP, breast milk shipping. Why would I go to the Employee Assistance Program? So that's number one. When we work with a health plan, is how are you spreading the word about your programs? How do people even know they exist? So whether it's a commercial program or a Medicaid program, you've got to get the word out, which means we partner very closely with the health plan and we work on a marketing strategy together. Because if, again, you don't know about the program, you're not signing up.
Mhm.
That's one step. First step is get the program commercial out there in the news, flyers at postcards and flyers and things like that at church or the supermarket, wherever you think your population is great, is partnering with the OBs, right? So we do partner with providers. And so that way, as soon as someone's walking in and they know they're under this health insurance, okay, let's get you signed up for this program. And then because we're working so closely with Medicaid and commercial populations, we will get information, demographic information, and we'll start calling. So making outreaches, and people, people are amazed at, oh, I have this program. Does it cost money? No, completely free. Part of your benefits of your coverage. So that first call is all about building trust.
Mhm.
And then they're like, okay. And then they sign up and we end up directing them to the app as well. So
Mhm.
that's the way we're accomplishing that engagement. And then once they're engaged, then we start the conversation. And then there's a health risk assessment. And that way we can classify and say, okay, boom, someone checked off that they have depression and they're struggling right away. That's a high risk, right? Let's
Mhm.
get that person help.
So
And so as we
preventive and
engage,
proactive.
right. And we don't just say, okay, here's a bunch of phone numbers for behavioral health specialists. We will be on the phone and do a three-way call, right? Dial in that provider or that front desk and help that person get the appointment. So
That's
warm
incredible.
handoff.
Yeah, that's incredible. So with all this, this is like implementing tech enablement,
Right.
but
High
not, but
touch.
like,
What is it? High tech, high touch.
but also, I hate low tech, but like human touch,
Human touch.
really. Yeah. But I would assume now with this tech boom and AI, that could hopefully be part of what's enabling or I guess, case management assisted, like we talk about
Okay.
physician assisted use of it. But do you see that as being part of the future of this industry?
I definitely do. I think there's some really cool stuff out there. So we have our platforms are proprietary, built in-house by Progeny Health people, and that enables us to get flexible with the tech, right? And get innovative.
Yeah.
Already in the background, we do have algorithms. So we have knowledge based upon years and years of data, able to have built in a length of stay predictor, a readmission risk predictor for the babies, a discharge predictor. So there are three major algorithms that are helping guide the nurses in their day-to-day work. And then as I think about that future, right, we know there's voice recognition where intonations or you can tell when someone's stressed, right? So your mom probably right away, when you call your mom, I know if I call my mom, she knows what's wrong, right? My kids now, what's wrong? There's something in our voices that give away that things aren't quite right. And so I really look forward to a time where we're taking some of that voice technology and building it into the case management work. So as you're having that phone call, someone can say, no, I'm fine, but the voice. So, and again, like with anything, like with any test, there's false positives and false negatives. So
Mm-hmm.
we have to vet that out. But I'm excited for AI.
So am I. And then you had mentioned about, well, with your past experience in the payer side of things, I'm curious to hear about what you think their challenges are and, within the space, outside of the space, and what is helping them to solve for that,
Yeah.
especially when it comes to patient outcomes.
So I think the first thing that's really challenging for the payers is every health plan is different, right? So we're not standardized, which means data is challenging. Every
Mhm.
health plan might want a same information, but it's captured in a different way. And so in America, because we haven't standardized our an EHR, an electronic health record, or how we collect data based upon certain conditions, and we do have some of that, like the CDC has some definitions, of course, for severe maternal morbidities, things like that. But at a state level, the Medicaid state, each state is asking for different reports. So that's really challenging because the health plans have to solve for that. And so we solve for that. We do a lot of this reporting because we're delegated to cover that work for them. And it is that part I really feel for them. There's tons of data coming in and going out. And I'd love to see a world where we put it to better use, where we get a bit more standardized so that
Mhm.
we can see how we're using it. And then they're trying to do the best thing, honestly, when it comes to what I see, certainly in Medicaid, and when it comes to moms and babies, the health plans really are trying to help their population that they're managing for the state. They really have the best intentions in that avenue. They're putting programs in place. They want to reach people because they know the more people they reach, the more people they can help.
Mhm.
So there's a lot of work in population health that goes unrecognized at a health plan level. All that case
Absolutely.
management work is necessary.
Yeah. And have you seen that health plans are collaborating more with companies like Progeny or
Yeah,
Blueberry to help to innovate and improve care?
I agree. They can't, I think they've realized it's too hard for them to do it, especially in these more niche areas. Pediatrics, for example, is still, they don't, the adults still outweigh the babies. So it's challenging for them. So therefore, like your company and ours, they're able to lean on us because we have that expertise. And
Yeah.
they're great partners. That much I will say, been great partners, had great conversations with the chief medical officers at many health plans. We
Yeah,
all have the same
absolutely.
goal is to help people.
Yeah, I agree. All right. So, what do you foresee as major shifts in health plan strategy and focus in the upcoming years?
So I think so value-based care, right, has been around for years. For years. There's been studies on it. So for others, value-based care is essentially you working with a provider to determine what the population of that provider looks like, figure out how to make sure the best practices are applied, and therefore help that provider achieve excellent outcomes by following those evidence-based guidelines. And
Hmm.
everyone wins, right? There's great outcomes. Sometimes there's bonuses involved for the clinicians, and you're saving money for the health plan, right? Because less healthcare utilization. For example, I adhere to my diabetes regimen. It's less likely I'll be readmitted to the hospital for diabetes
So,
care.
better outcomes for parents. I always say
Absolutely.
parents, but people,
For
which
people,
is a
right?
win-win-win.
It's
Lower
it's
healthcare
just a win
costs,
all the
better
way around.
health. Exactly.
Right. Yet it hasn't been fully adopted, right? There's been challenges in getting providers to jump on board. And so I think there's going to be a change in how is that looked at? What is the best model for compensation that keeps our providers motivated, ensures the best care. So there's some models being talked about that how are we going to change that value-based care contracting to something else? We still have a lot of fee for service.
Right. So what does effective leadership look like in a rapidly changing healthcare environment?
Oh, that's fun. Okay, effective leadership. I actually just got off the call with a chief medical officer of a health plan right before you and I talked. And she had a new leader who came in above her. And she was very challenged because this leader, his leadership style didn't match hers. And we started talking on our chat about the different leadership styles at health plans and what works and what doesn't. And there are essentially 6 major leadership styles, right? So I have had an approach of a servant leadership style for the most part. This other person that brought in was more coercive. So very forceful, like my way is the highway, which on one hand, I can see working in a situation where someone has to come in and completely revamp a team or completely, look, it's challenging financially for health plans, for hospitals, et cetera. You also have systems where a hospital and the health plan are combined, right? So you do have some leaders who are coming in and they're tasked to look at things very rigidly and just cut because financially it's hard. So this person had no choice but to be coercive in his style, I think, in order to get the job done. I really love servant leadership, where I do believe bringing the right people in, mentoring them, serving them, helping them rise up. So I think it's a combination of, I think about mentorship and leadership. So there's the hummingbird parenting, which is my version of parenting. I'm not a snowplow. I'm not a helicopter. I'm like a little bird that occasionally jumps in there and makes little suggestions and then
I've never
lets
heard
you.
of these other
Oh, there's
versions.
several
I
different
just heard about helicopter, which I probably should own, unfortunately.
Yeah, look up hummingbird.
Okay. Wait, tell me
Definitely.
more. Okay.
Yeah, my kids also were like, "Oh yeah, you weren't snowplow. You weren't around enough to be a snowplow parent
Okay.
or a helicopter parent," which was good for me because I think if I wasn't working, I would have been one of those types. But so I think of that servant leadership along the same way as I see someone doing something, I want to let them do it. I know it may not work out well, but they really want to try it. So I'm like, go try it. Same thing in the NICU. How many times did a student or a fellow say, I want to draw these labs? And I'm like,
All the time.
right? I'm like, okay, you
Every
want to draw
day.
those labs. That's not your heel. That's the baby's heel. But I'm going to let you do it. And then you're going to tell me if it was worthwhile or not. And then you're going to think about it again next time. I want you to think about the baby's heel. And do you really need that lab? So those are the kind of things you want to watch someone grow. At the same time, as a leader, you have to get the work done, right? So there is that balance of, at some point, the decision maker has to come in and be that final say. I don't think it has to be coercive, but it does have to be, the leader does ultimately have to kind of gather the cats, help the cats make a decision, make them feel like it's their decision, right? Especially if it is their decision, then that's great. But sometimes that person does have to override, and that's hard. It's a balance.
Oh, yes. And they have to trust the decision that you're either leading to or making.
Right.
So you have to establish that too.
My team said to me the other day, they said, Linda, you are really good at listening to us and really good at letting us do what we want, and really good at shutting us down when you disagree.
That's the hardest part, to tell people no and to get rid of the I want to be liked feeling, and to know that might, or to hold on to that while telling them no is a
yes
very tough skill to establish. But that's incredible.
It's hard because
That's a
you want to
great
be friends
compliment.
with everyone.
I do. Or you want them
I
to
finally
like
learned
you.
I'm never going to please everyone. I finally took a while, accepted it a while ago. I'm like, you know what? No one's going to be happy with me all of the time. We send out, after every meeting, right? Large company meetings, we send out surveys, just like many companies. What do you think of the meeting? There's always great comments, and there's always a few negative comments. And you just learn as a leader, we're never going to please everyone, but let's please most of the people most of the time.
Yeah, absolutely. It's great advice. Actually, I was going to ask you what great advice you have for the next generation of leaders. Anything else you want to add to that? Any nuggets of
So the one thing I always remember is you're juggling a lot, especially I'll speak as a woman leader, right? Coming out of a women's college that said, you can do everything. You can, you know, get the bacon, fry it up in a pan kind of story. And I think what a lot of us learned is we can do everything, but we're not going to do everything well. And accept that. I'm going to miss one of my kids in second grade had like a reading or whatever. And my friend's like, where are you? I'm like, I'm post call. What's going on? She's like, you have to be here. And
no.
thankfully I had so find good people who have your back, whether it's in your community or at work. Find people who have your back and who are there when you need them. I think that's really important. And network. If you're in a company, just reach out, say, hey, you want to grab some virtual coffee? It's fascinating to me how great it is just to reach out, even in this virtual world. Like all the time, people reach out through LinkedIn, and I take 1 hour out of my week every week to help someone who's reached out to me and said, I'm looking to transition from clinical to non-clinical. And I will spend 1 hour a week talking to that clinician, giving them options. And I'll even say, send me your resume. I'll take a quick look. Because it's a big leap and not a lot of people are there to guide you. And I'm not saying we're having a massive exiting of people practicing, but people are looking for other things. It's very hard to be a clinician, especially in certain fields as you get older and older. It's hard to be up all night in the NICU. So I do have quite a lot of women, mostly women, reaching out to me saying, I'm just looking for something to give me better balance.
Makes a lot of sense. I see that a lot too. People just need a break from the burn.
Yeah.
It's tough. And also exciting to know that we could use our skills in another way that will impact much greater populations.
Yeah. And the last thing I would say is keep learning. So, right, I left the bedside more and more, and I learned about the business of medicine. And I started reading the Harvard Business Review. I never in a million years thought I'd read the Harvard Business Review. That was for people who went to law school or business school. There were a lot of words. There were no pictures in the books. I didn't like those things. That's why I liked what we did. There's a lot of pictures. And I will say, just keep learning. And now with AI, I log on and look at AI courses, all those free AI courses, because there's a lot to learn.
So much, yes. All right. Well, anything else that I may have missed that you want to add in about whether it's value-based care, Medicaid, Medicare, outcomes?
My one thing is I really think clinicians have to understand the whole spectrum of the healthcare system. I think it's very easy to get stuck in your silo and just focus on what's in front of you and blame everyone else and blame the insurance company. I think we have to see both sides of the fence and understand that we are working together. The insurance companies aren't going away. Patients in need aren't going away. So we, as clinicians, have to figure out how to help the system work better together. Quite honestly, that's really important. That's the only way we're going to move forward and change what's happening healthcare-wise in America. We need better outcomes.
Actually, that brings up something else I've been curious about, maybe some insight on. When we come together, our physicians are using their voice. It's in the space of advocacy for something they're passionate about. And a lot of these initiatives do come from the federal government, especially like maternal care, maternal health care was really brought to the forefront in the last few years, thankfully. And that's why I think a lot of strides have been made. What can physicians do in terms of using their voice in a really effective way?
So I've learned more and more. So there's all sorts of advocacy groups that I've learned about. Like my dear friend who's an anesthesiologist goes every year to Albany for the day, and there's an advocacy day for anesthesia. So pediatrics has advocacy. So in your specialties, connect. For us, it would be the American Academy of Pediatrics. There's tons of groups that are doing advocacy. I wish I had more time. Like that's my retirement job, is to get more involved in advocacy. But that is absolutely, every single specialty has an academy of something, and they have whole people focused on that.
Yeah.
I would say that's a great start.
Yeah. All right. Well, thank you. All right, Linda, I've loved having you on. Thank you so much for taking the time. I've learned a lot. I think our viewers will also learn a lot. So thank you.
This was fun. Let's do it again soon.
I love that. Thank you so much, Dr. Genen, for joining us on the Blueberry Pediatrics Podcast. You can reach out to Linda via her LinkedIn page for any more information on maternal health care or any of the topics we talked about. Thank you for tuning in today for our episode. Be sure to subscribe to the show for more episodes. If you love the show, please be sure to leave us a 5-star review.